So, so most recently, we saw the emergence of the guidelines that came out from the American Association of Liver Disease. It is the very first guideline focusing on malnutrition, frailty, and sarcopenia. And one can imagine that for decades, we have seen patients with significant impact of muscle loss, their frailty, and their nutritional status. And still, we did not have any formal guidance. This is a very first step in the right direction. I think there is a lot more work to be done, but at least kudos to the team that really put forward such an important work to guide physicians in at least conceptualizing, organizing, and thinking about this problem more cohesively than ever done before. So here they highlighted three big constructs: the malnutrition, frailty, and sarcopenia. And I will just like touch upon it, that although they are theoretical definitions that are generally derived from the physiologic changes associated with aging in primary context. However, they have refined the operational definitions more so applicable to the population of our interest, which is cirrhotics. So as seen here, malnutrition, they broadly classified as a clinical syndrome that results from either deficiencies or excesses of nutrient intake or imbalance of essential nutrients or impaired nutrient use. And in operational context related to cirrhosis, they termed it as an imbalance, both like either deficiency or excess of nutrients that cause measurable adverse effects on tissue or body form, like body shape, size, composition of function, and clinical outcomes. In terms of frailty, which is defined a clinical state of decreased physiologic reserve and increased vulnerability to health stressors. In terms of cirrhosis, this means phenotypic representation of impaired muscle contractile function. For sarcopenia, the theoretical construct is a progressive and generalized skeletal muscle disorder associated with an increased likelihood of adverse outcomes, including falls, fractures, disability, and mortality. While in terms of cirrhosis, this means phenotypic representation of muscle mass loss. So with that background, I'd like to highlight why do we really care. So this conceptual overlap between frailty, sarcopenia, and their contributing factors are highlighted in very elegant review from some of the authors who formulated these guidelines. And as can be seen here, frailty and sarcopenia are overlapping to an extent, but also have independent consequences and contributions. In terms of liver disease per se, the refractory ascites and hepatic encephalopathy are two most important factors impacting frailty. And on the other hand, physiologic terms like aging, chronic disease associated muscle wasting, or pathologic changes, inactivity, both socioeconomic and environmental factors, as well as inadequate caloric and protein intake and associated comorbidities, all together have variable impact. And that is what makes it more challenging to really like objectively evaluate and assess, as well as develop interventions that can be objectively intervened and measured. So that gives us like some background of the complexity that what we are dealing with the end organ damage, what we may call as frailty and sarcopenia in this special context with muscle. So what are the factors that contribute to malnutrition, frailty, and sarcopenia, and how these relationships are related? So the committee broadly thought that this is underlying common pinning is malnutrition. And there are a variety of factors as highlighted here, which are directly related to cirrhosis or other systems, as well as the physical debility or inactivity and the environmental and organizational factors I just highlighted. To list some of these etiologic factors, we know that in cirrhosis, there are significant changes in the synthetic function of variable important cellular organelles and signals. There is fluid retention. We know how it affects the brain with cognitive dysfunction. There is also change in the metabolic perturbations, including hyperammonemia, and very well established now that there's anabolic resistance. So in trying to build muscle mass, we do face some uphill tasks. Then etiology of liver disease can have variations, including alcohol, non-alcohol, cholestatic liver disease, and so on and so forth. Similarly, other comorbidities, including diabetes, insulin resistance, endocrine dysfunction like thyroid, aging-related changes, all contribute in variety of forms, including the visceral fat accumulation. Now, physical inactivity is very well observed in most chronic conditions, and cirrhosis is no exception. And as a result, muscle disuse is very common, and that contributes actively in muscle wasting and frailty. There is also cardiovascular deconditioning, both from the performance standpoint as well as underlying structural and physiologic changes that can contribute independently for outcomes. There is a lot of focus now on social determinants of health, because that could be something that is actually driving other factors. So if we recognize those early, and those that are in health disparity zones, whether they can benefit with like policies and protocols, that would be a great area to focus on, especially from population level, which leads to late diagnosis, lack of assessment, and then there's obviously challenges with managing the comorbidities and the underlying primary problems. So all in all, malnutrition is in like a cross section of all these variable etiologic factors that lead to either excess intake or lack of adequate intake of both macro and micronutrients. The clinical phenotypes of this malnutrition, which is what we are likely going to focus most of this talk, is about frailty and sarcopenia. And as seen here, the authors and the experts felt that they are interchangeable, or they can go from one to the other. And I think they are largely correct in that extent that they can interplay in one and the other, like sarcopenia can promote frailty, and frailty can lead to muscle loss based on physical inactivity and other factors. It may have a variety of outcomes, which are both direct health related as well as quality of life related. So increased decompensation risk, healthcare utilization, health related quality of life is significantly affected. And there are transplant related outcomes, and of course, the ultimate outcome is death. So sarcopenia and cirrhosis, I would like to give a little background. And we pretty much know that there are enough data now, which is beyond the scope of this talk, but I'll try to summarize some of the articles and some of the data, that this is one of the most common complications associated with cirrhosis. Predominantly, there is both loss in muscle mass and strength, which now can be independently evaluated more in the domain of frailty. Adversely, it affects the survival, the quality of life, and other complications of cirrhosis and post-liver transplant outcomes. Just to give an example, what sarcopenia or muscle wasting looks like. So this is one of the very initial works from Montelaza and their group in Canada that kind of really highlighted the importance that we can leverage existing data systems such as radiologic parameters and measure at level L3 using CT scan and some of the sophisticated tools and softwares that can give us a measure of identifying muscle, which is highlighted here in red, taking at the level of L3, and come up with something called like a skeletal muscle index, which utilizes the body weight as well as the height. And so based on that, they came up with a cutoff that the skeletal muscle index, which was over time refined, to 52 in men and 39 or I think in women. And here, in someone with the skeletal muscle index of 49 is considered like sarcopenia compared to the skeletal muscle. As you can see here, the swath around the L3 vertebra is significantly depleted. So are the abdominal rectus muscle over here. So in comparison to a skeletal muscle index of 70.8, this was significantly lower and fell in the threshold of what they defined as sarcopenia. And based on that, they commented that it does affect the outcome on survival. And this can be clearly seen that those that did not have skeletal muscle index less than 52 and hence no sarcopenia were almost 30% to 40% better in terms of surviving in next 2 years, even though they have cirrhosis. Now, there was a data that came out from Cleveland Clinic by Dr. Dasarathi that showed that muscle mass, when improved, can make difference in its outcome of survival. And post-tips, they noticed that these patients had improvement in their muscle mass, and as a result, there was a significant survival advantage, almost 50% improvement in their survival post-tips. So I think like there are, this was one of the very important observations that stem from some of the basic science work that I'll probably show in one of the last slides towards the interventions in the treatment options for sarcopenia and potential future scope for those. This another study from Puneet Tandon and group did come. Sorry, I somehow got a little typo here, but sarcopenia predicts poor survival in cirrhotics with low MELD score on OLT waiting list. This was one of the very important papers to focus on, that traditionally we use MELD score as one of the important outcome measures, prognostication, listing for liver transplant. And what Punita and group found was that even though people who had MELD score on less than 15 and they were non-sarcopenic compared to those that were greater than or equal to 15 and both sarcopenia, they were similar outcomes. So sarcopenia with low MELD score was as worse as MELD score greater than 15 in terms of outcomes. So suggesting that even in low MELD score, the outcomes can be impacted just based on that those patients have muscle wasting. So it is important to recognize that sometimes we often get misled by the concept that, okay, MELD score is low, but if they have frailty or sarcopenia, especially this study had shown about sarcopenia, that it can negatively impact survival while the patients are being waitlisted. So sarcopenia is an independent risk factor for increased mortality in cirrhotics, more importantly in those that are with MELD score less than 15. So this was one of our studies that I tried to pilot at the Institute of Liver and Biliary Sciences in India to try to see that most of the data are coming from the West. How does it may impact in people who are from the Asian domain and Indian context? So this is an exclusive group of alcoholic cirrhotics. What we noticed here is that we didn't have an outcome on survival. That's why it was here in Liver International. Still, we noted some important observations that as the disease progresses from child class A to C, you can see that clearly there is the red muscle, which was seen here in the normal individuals that were being evaluated for liver transplant compared to those with child class C cirrhosis. There was a lot more wasting of the muscle, almost non-existent abdominal muscle compared to the thinness out here. And as you can see that there was an increase, the bluing, which is what is the visceral fat. And so visceral fat was higher in child class A and B, which is more metabolically negative. And those patients do have like higher insulin resistance and probably negatively impacts their other portal hypertension related outcomes. So to regroup that sarcopenia can impact cirrhosis in variety of outcomes. These include mortality both before and after liver transplant, decompensation, reduced quality of life, increased risk of infection, and prolonged hospitalization. So this was an elegant meta-analysis that came out from Van Wood and group that highlights the impact of sarcopenia in cirrhosis both pre and post-transplant. On panel A here, you see the pre-transplant while they are waiting and the waitlist mortality is evaluated. So as seen here from multiple of those studies, some of which I already highlighted, that where there's no sarcopenia, they had better outcome and significantly improved. So no sarcopenia had a protective effect and favored survival with a hazard ratio of 1.72. Similarly, this is panel B and C are post-transplant outcomes, and where favor survival was noticed with those that did not have sarcopenia compared to those that had sarcopenia with the hazard ratio of 1.84. They also analyzed data where there was higher muscle mass, and that was again analyzed, and it had a protective effect, just approaching the confidence interval 0.96 to 1. So overall, suggesting that there is a big impact both pre and post-transplant in outcomes with patients having poor muscle mass or those that have good muscle mass or preserved muscle mass, they are surviving better post-transplant as well. So here is just like a key proposed mechanisms of sarcopenia and cirrhosis. A variety of factors play a role. That is why it is challenging to assess and integrate all together. But primarily the dietary intake, which is low, and there's a stage of accelerated starvation, which leads to increase in fat and muscle catabolism. I'm sorry, something is happening. Okay, and primarily underlying liver disease affects the urea cycle, as well as increase in bacterial translocation, endotoxemia, and pro-inflammatory cytokines all promote the imbalance between protein synthesis and autophagy and proteolysis, which is one of the key mechanisms how muscle wasting develops. As a result of the urea cycle defects, there is hyperammonemia, and together it contributes through increased myostatin, which is a negative regulator for muscle synthesis and anabolism, as well as decrease in the branch chain amino acids. Both are potential targets for interventions, and there's also associated low testosterone levels that also contribute to decrease in the muscle mass. Simultaneously, there is decrease in the physical activity and increase in the sedentary lifestyle. Together, these affects the mitochondrial and ribosomal function and negatively impacts protein synthesis and promote protein catabolism. There can be additional concomitant toxic agents. Most commonly in our population is alcohol, and together there is a bigger signal towards decrease in the muscle mass and the decrease in the muscle contractile function. So how can one quantify some of these top things that we talked about? And here I introduced the frailty concept as well. So this can be a multidimensional frailty, like in a global sense, which can be assessed by frailty index, or there are some other scores like clinical frailty scale or hospital frailty risk score, which is evaluated in inpatient setting. Then there can be a more common practical physical frailty disability, which is liver frailty index that I'll talk about, and then the short performance test, as well as activities of daily living and Karnofsky scores. Those were mostly evaluated in inpatient setting. A very simple gait speed and 6-minute walk test can be used. So these are the fried frail phenotype that they gave, and then the hand grip strength can combine both frailty and sarcopenia. Sarcopenia largely so far has been focused on imaging-based methods, which are predominantly either CT scan or to some extent MRI or the DEXA scan. There is an emerging role for both bioelectric impedance as well as the ultrasound of the thigh, which was specifically looked at in inpatient setting. There have been the exponents of supporting and not supporting BIA, and I think the ease and the ability to perform it with knowing limitations, as well as if it is longitudinally followed, it adjusts for any of those variations or confounders that are generally discussed about. So I think it is underutilized and has a good potential to be incorporated in clinical setting. So this just highlights some of the key studies that show association between sarcopenia and frailty in patients with cirrhosis. And I'll talk about a couple of these studies, but just to highlight that the study from Yadav and group were mainly the patients were listed for liver transplant. It had both sarcopenia and the frailty assessment where they used the 6-minute walk distance, and they did not see a good correlation between muscle wasting or frailty assessment. So they reported a poor correlation between sarcopenia and the 6-minute walk distance. And what was key here is that 6-minute walk distance was the main predictor of waitlist mortality in their study. Similarly, Wong et al. Did a waitlisted study for nearly 300 patients. They appear to have a very similar approach, and they also had the physical performance battery, the short performance test, which is what emerged in their outcomes as to be an important predictor of waitlist mortality. So you can see that there can be difference in how they are assessed, although the SPPB does include one of the measures as the 6-minute walk test, but this is a little more elaborate. So it is important that whatever can be clinically, reproducibly, and without impacting the workflow be implemented. So I think like 6-minute walk test, walk distance certainly has a lot more value and bang for the buck. Then there's also a study from Sinclair and group that looked for 145 men. They also studied the testosterone in that, and they noticed that the hand grip strength, when it was combined with the MELD score, it was superior for the prediction of waitlist mortality than MELD alone. So which again is an important indication that utilizing the assessment for frailty and or sarcopenia can add value to existing systems such as MELD, which is such a critical prognostic marker in our population for transplant and outcomes. Similarly, Dang and group had a 6-minute walk test and CT scan. They also noticed a weak correlation between skeletal muscle index and the 6-minute walk test. And although it shows like significance, but see the association is so weak, R of 0.022. So sarcopenia and low 6-minute walk test were independently associated with mortality. And they also noticed that those that had both sarcopenia and 6-minute walk test slow, they had the worst prognosis. So this study from Yadav's and group that came out from Arizona, they looked at the 6-minute walk test, but not sarcopenia, independently predicted waitlist mortality. As clearly noted here, the survival on sarcopenia, no sarcopenia is not significantly different. While here, if you have 6-minute walk distance less than 250 meters versus more than 250 meters within 6 minutes, you can see such a huge difference in outcomes as early as even in 6 months that they have increased mortality, which kind of like is almost 80 to 90% within 2 years. So as simple a test as 6-minute walk distance can be a very simple and applicable clinical tool in our practice. So then talking about the Sinclair study where they use hand grip strength, and I'm trying to focus on things that we potentially can incorporate and adopt in our clinical practice. So this is such a simple tool. We use it often in our metabolic liver clinic as well, where we are planning interventions to assess hand grip strength. And that's a little different class where they're generally non-cirrhotic. But in cirrhosis, the hand grip strength adds more prognostic value to the MELD score than the imaging-based measures for muscle mass. And as can be seen clearly here, for the hand grip strength, if you look the mortality and the transplant outcomes, it did not show significant difference in the transplant outcomes, but lower hand grip strength was significantly negative predictor for probability of increased death if their hand grip strength was less than 30 kilograms, which is close to about 65, 66 pounds. So our dynamometers gave us value in pounds, and this was in kilograms. But when you see combined with the standardized hazard ratio for mortality, MELD score was not like as predictive in terms of the probability of both transplant and mortality as compared to the hand grip strength alone in this particular study. So that brings to the point, like, what do we actually do in our clinical practice? Came in Jennifer Lai and their group with tremendous focus and work in this area. I think they led the field in the frailty, and they came up with something that can be more objectively like assessed, as well as is not as time consuming, as well as simple, and as well as something that can be applied over time. So based on some of the literature from the geriatric and gerontology side, they utilized grip strength, time chair stands, and balance testing, and integrated them together into an index called the Liver Frailty Index in patient population, specifically the cirrhosis. In grip strength, they measured 3 trials and then averaged their value. They use subject's dominant hand using a hand dynamometer. Most common one that is utilized, and at least in the US, is the JAMAR, J-A-M-A-R. And people can buy it on even Amazon, probably around $300 or so. So a very simple thing that can be applied. Then time chair test, measure the number of seconds it takes to perform 5 chair stands with the subject's arm folded across the chest. And you have to be very careful that many patients may not be able to do it, and there's a risk of fall, so that needs to be assessed. Balance testing, this is another important marker, that there are 3 positions to assess balance, and the number of seconds that subject can hold in those positions is what is counted. It is maxed out at 10 seconds. So if you have achieved 10 seconds for that patient, they do the best. But if they cannot do 10 seconds, then they get a negative score. So feet placed side by side, semi-tandem walk and tandem walk, or tandem position to balance. So when they were using these 3 things, they adjusted for gender, and they utilized this formula, which is also available as a calculator that can be plugged in and give you a value. They refined this from cirrhosis and transplant waitlist population and came up with a liver frailty index of greater than 4 or greater than or equal to 4.4 as frail. So those are important because their original work in 2017 was cut off greater than 4.5, but with refining together, including the transplant waitlist, transplant mortality, and outcomes, this was the more refined formula. So those patients who have liver frailty index less than 3.2, they fall into robust category, and pre-fail and frail. So I think like most of people have focused on the frail part, and there is a good chance that people should look and start targeting in the pre-fail category and affect and impact the outcome. So this is how they noticed those that were robust and frail. You can see that similar MELD score they had decrease in the mortality even with the same MELD score compared to, increase in the mortality with the frailty. I think there's something happening with this. Okay. And in case, if you want to see how the dotted line, if you see that MELD of as high as 23 with the robust, the frailty index less than 3.2, they can have a similar survival as a MELD of 14 with frailty. So if it is robust, even high MELD score could have a similar survival, and anything like added to frailty worsens it to that score, and almost 35% mortality within a year. So clearly demonstrating that liver frailty index has a significant impact on survival. So then they looked at it whether the presence or absence of the portal hypertensive complications like ascites and encephalopathy make any difference. And it was noted that frailty significantly increases 12-month waitlist mortality for liver transplant, both independent of ascites and encephalopathy, as can be seen that even in no hepatic encephalopathy, no ascites, the waitlist mortality is still like 25%-ish. While this does increase with the presence of ascites and encephalopathy, and when both are present, it is comparable to either of their present. So knowing that, like a very simple task would be that each and every individual who has either ascites or encephalopathy at least get evaluated and assessment. If they fall in the pre-frail category, you have a good chance to kind of slow their progression or outcome can be impacted. If they are frail, still we have chance to kind of work on trying to decrease that frailty score and see if that can impact the outcome. So change in liver frailty index scores every 3 months by trajectory group shows that there are all possibilities happening. So they can be steep worsening, they can be a moderate worsening, they may remain stable, they may improve. Overall, this is where they become. So the whole idea is that if we can maintain the stability or improvement by interventions in early recognition, we can avoid their worsening and impacting the worst clinical outcomes. So this very elegant work from, again, Jennifer Lai and group looked at the cumulative incidence of waitlist mortality by change in the liver frailty index. And as can be seen here, that only about a sixth of patients did show improvement in liver frailty, while majority worsened, like 23% to moderate worsening. And so nearly 50% or half of the patients showed worsening, and half of the patient either remained stable or improved. But see the impact over time. So those that improved the frailty for every 3 months, even then the 2-year mortality was 7.3%, but this was 1/5 or just about like a 5-fold higher mortality in those that have severe worsening. So there is a lot of impact on how the waitlist mortality is negatively impacted, more so at the first 6 and 12 months. So we have a lot more bang for the buck to target and reverse this order from worsening to at least achieving closer to stability, best if we can achieve improvement. And this is the Kaplan-Meier curve shown for the survival, that worse outcomes versus improved frailty had cumulative incidence of low waitlist mortality compared to those that had worsening frailty. So how does this can be used in clinical practice? So the changes in the baseline risks, they predict the waitlist mortality. So every 0.1 unit worsening in 3 months can have a negative impact in stepwise multivariate analysis, 2-fold higher risk of like negative outcome. So if we are able to track their liver frailty index over time, and as I said earlier, if we can keep it stable or reverse or improve, then we are doing great service to the population that deserve intervention and change. and MELD sodium per 5-unit increase was less, almost 1.11 hazard ratio compared to the Liver Frailty Index, which has 2. So clearly showing that a simple measure of Liver Frailty Index can be a very important tool in our clinical practice. That also brings to other important measure of assessment. For long, Karnofsky performance status is utilized in evaluating their performance status pre-transplant. And so Dr. Tulawat and group looked at this very nice study. They looked at whether the Karnofsky performance status pre-transplant impact the post-transplant outcome. And based on the KPS at transplant, which was 40% and below, which means that you're dependent for most of your activities on other things, they performed poorly. If they did improve their Karnofsky post-transplant by 10 to 40%, or 50 to 70%, or 80% or higher, it significantly improved their survival probability as noted here. So the red one is 50 to 70% improvement in Karnofsky status compared to no improvement, which is the brown here. So one can clearly see that there is almost 50 to 60% survival advantage by improving the performance status by 50 to 70%. Clearly implying that performance status pre-transplant and its improvement post-transplant can impact outcomes long-term. And this is, imagine 108 months, which is nearly 10 years of the follow-up. This was seen similarly, those that had KPS of 50 to 70% range, even in that population, no improvement versus any improvement, either 10 to 20% or greater than 20% or 30% or more, showed at least like twice an improvement in their post-transplant outcomes. This was also evident even in those that had high performance status at the time of transplant, which is like in the 80 to 100%. And if it did decrease, then it negatively impacted their outcome by about 10 to 20%. Survival was decreased. So clearly performance status pre-transplant and its change post-transplant has a bearing on survival long-term. Now, what are the key proposed mechanisms for frailty in cirrhosis? Majority of those run from like the brain, which is hepatic encephalopathy related. There is an all over systemic inflammation. So the inflammatory milieu is one of the other drivers. Increasingly recognized low testosterone and the other low hormones endocrine. And now there's an active area of investigation how the microbiome and dysbiosis could be implicated in frailty. Complex issue itself, and as we saw that how frailty and sarcopenia are such multifactorially impacted and add the complexity of all these different variables, but they all have shown some evidence to suggest that they may impact the frailty. And so these are some of the areas of potential investigation for people who are interested in that domain. So what can we do to be able to make some difference after having seen how these things are implied? So there are a few important things like recognizing and primary prevention. That's the best if one can do. But if we miss the boat, whether we can do anything for secondary prevention, and if we get referred those patients and we are at a level where we can offer tertiary prevention, we can at least offer that. So very nicely simplified that here you prevent the development and delay the onset. Here in secondary prevention, you try to diagnose early, initiate treatment early to minimize the disease progression. While here the disease is already progressed, in tertiary prevention, you want to rehabilitate and attempt to reverse that. And then we can use different diagnostic toolbox that I'll go a little bit in the next couple of slides. But basic aspects are in primary prevention, do a malnutrition screening and assessment of muscle function. In secondary prevention, evaluate the etiologic risk factors that we discussed in the initial slides. explore the dietary preference and barriers to exercise, and then reassess for progression of malnutrition, frailty, and sarcopenia despite primary and secondary prevention efforts. So that's our diagnostic toolbox. In the management toolbox, we need to act on these patients. So how can we prevent primarily? We need to educate both patients and their caregivers. We also need to encourage positive health behaviors, empower both patients and specific skills. And I would like to add that we also need to educate our providers, primary care providers who have more direct contact for a variety of other medical comorbidities, so that areas can be leveraged. So partnership with your primary care team and other consulting teams will be of value in primary prevention. Secondary prevention, apply the management toolbox we'll talk about, co-manage with dietitian and exercise team if there's availability. If not, at least try to use some public resources that are available. And those that are targeting the tertiary prevention, there's certainly a multidisciplinary team that's needed, from dietitian to exercise physiologist, therapist, health behavior specialist. So you can see that as the disease progresses, more and more healthcare resource utilization is required. And so the best goals are to try to prevent at a primary level, and as the resources will be less needed, and prevent overall occurrence of undesirable health outcomes. Who should we do it for? I think it should be applied to all patients with cirrhosis, as the expert committee recommended. You must screen for malnutrition as well as sarcopenia and frailty. If they are normal, then continue to reinforce and follow as required, like 6 to 12 months or frequent, depending on the underlying situation. Either is abnormal, then identifying the contributing factors that we talked about, and then work on those management tools and strategies, and then reassess how those things impact, whether it is stabilizing, reversing, or it is not holding it back. So just highlighting what these are, I already talked about the clinical questions like Karnofsky performance scale, frailty scale, activities of daily living, which are there and can be captured. So the idea is, how can ancillary team build it in the healthcare record system where these things are available, and if this can be implemented, it will be very important integration of performance improvement in patients and recognition by physicians across the health systems. So physical findings, by the time we notice the wasting in the muscle, it's a little too late. We are already dealing with stage of secondary prevention and or tertiary prevention. Easy to recognize if they're not able to walk without a walking aid, or while they are taking getting up chair test can give us. Objectively, we can measure a lot of these things that we talked about already, from CT scan at L3 level to liver frailty index, hand grip strength, 6-minute walk test, speed test, and in pediatrics, they still and can easily apply tricep skin fold, avoiding any exposure to radiation. These are some of the factors that we are able to identify, and in a good point is the hunger vital sign. So food and nutrition is becoming an important recognition of social determinant. And simple question like, within the past 12 months, were the patient and the family worried whether their food would run out before they got money to buy more? So very simple test to assess the inequality on access to food. Physical inactivity can be assessed, how many days they've spent 30 minutes or more of physical time, enough to raise the breathing rate. And then of course, physical exam findings when it has already progressed quite a bit. And then these are some of the objective measures: smell, child class, testosterone level, and from the other steps like getting more and more integrated about the patient fitness trackers. So some of the key proposed targets to treat frailty in cirrhosis. So recognizing that these are targeting the brain, so most of these are co-associated with hepatic encephalopathy. So recognition, preventing, and treating that is important. Of course, avoiding neurotoxic substances and highlight again importance of alcohol cessation. Easier said than done, but it does make a huge impact in those that are able to. Also modulating the inflammatory cascade, so prevent and treat inflammation and infection where possible to recognize and modulate. This is an area of little controversy, and however, something to be pursued with caution. But there are some good promising data coming from India, and published. The previous one was Sinclair and group that testosterone therapy with low levels can at least improve muscle mass and function. Microbiota rehabilitation is gaining a lot of attention these days, and certainly an area to actively pursue. And we'll hear a lot more about this in this coming decade. So these are some of the key proposed targets to treat sarcopenia, as we talked about from the mechanistic constructs, targeting the bacterial translocation and toxemia. Same thing, focus on treatment of infection, maximize and optimize the complications of cirrhosis. Where suitable and listed and transplanted, that is the fix, transplant their livers, improve the nutritional intake, decrease the period of fasting by increasing evening snacks and early morning meals to be able to decrease their starvation period, alter their ammonia levels, which still is debatable, but at least one of the mechanisms to decrease the branched-chain amino acids and negative impact through myostatin. So follistatin, myostatin antagonist are, and the branched-chain amino acid supplements are tried, and there are some good promising data from Dr. Dasarathy's group that looked at that. Improve their physical activity, and then obviously antioxidants, debatable, not enough data to support in testosterone, as we talked about. So just like branched-chain amino acid can affect the inflammatory cascades and decrease proteolysis, and so it can benefit both in decreasing the inflammation and proteolysis, as well as oxidative stress, and again, negative impact on NF-kappa B, promoting anabolism instead of catabolism. So this study by Dr. Dasarathy's group, seen in rats, demonstrate that how follistatin, that myostatin antagonist, can impact both improvement in myostatin levels were high, and then more so than this, they were able to over time reverse this in terms of follistatin therapy with the what you call the activin receptor, which is where the myostatin acts. They also noticed that there was a decrease in the activation of the receptor where myostatin binds without impacting myostatin. So it is the mechanism through which they also lowered the P21. Both of these were able to foster and promote muscle synthesis or protein synthesis than protein loss. In the Portacaval anastamosis rat model, they also demonstrated that follistatin was able to increase the, in the follistatin model, they were able to increase the activin receptor, and as well as the CDK was not much changed. So the concept of anabolic resistance, which can affect the response to treatment. So likely impaired mTOR signaling response is what is implicated in this. And this can be potentially overcome by leucine and resupplementation with amino acids. And leucine is likely to result in increased utilization of other essential amino acids. That is what one of the recommendations came from the journal Cachexia. But this was based on the data from Dr. Dasarathy's group. They gave the branched-chain amino acid leucine and then they obtained muscle biopsies to see the incorporation of that, as well as how it impacts the protein synthesis cascade. And as noted here, those that received the therapy in cirrhotic post-leucine intervention, the phosphorylation of P70S6K as well as PS6K suggested that there is an increased protein synthesis compared to and change in the reversal of the autophagy in the muscles in those that are alcohol patients, in the muscle of alcohol patients. So this is a very elegant high level study. This certainly needs to be further tried in randomized clinical trial fashion to be able to utilize and demonstrate the value of branched-chain amino acid leucine enriched. So what can we take home in terms of nutrition prescription in broad terms? If one has to prescribe nutrition, it's best to know what's their burning ability. So indirect telemetry is what they recommend, but I see that this is rarely available in clinical practice. So best way is to use the predictive equations based on dry weight. And in obese, these are again expert committee data from ASPEN or the Society for the Critical Care Medicine here in the US, and has not been very thoroughly investigated in cirrhosis field. So I would be a little cautious. However, this is what we follow because there isn't great evidence to support. At least 35 calories is what is supported. And the BMI intake 25 to 35 if BMI is under 40, and 20 to 25 calories if BMI is greater than 40. I would lean towards this recommendation more than just moderately hypocaloric, only 800 kilocalorie diet, because these patients already are in a stage of accelerated starvation. And if you further starve them, you are promoting that particular component. So protein for non-critically ill, 1.2 to 1.5 grams, and in critically ill up to 2 grams. Now there are debates whether this really helps at that level, but this is the recommendation from Critical Society, and this is from the ASPEN Society. Of course, the timing to try to decrease your starvation status in these patients: early breakfast, late evening snacks, and more frequent while they're awake. And then, of course, the branched-chain amino acid that we talked about, still it's insufficient evidence, but if were to be delivered 0.25 gram per kilogram per day. These are some of the exercise prescriptions, and I would not go into the full detail, but suffice to say that before giving exercise prescription, assess the safety, and more importantly, cirrhotics are at high risk for high-risk varices are important, that they can it can increase intra-abdominal pressure and risk for the GI bleed. So they should be on prophylaxis and ensure that in encephalopathy and ascites, they are optimally controlled. Similarly, cardiopulmonary safety screening is very, very important in this patient population who are at risk for arrhythmias as well. So then make sure that they are able to perform what is recommended. Although they use this model both in the review by the experts and the guidelines that are that I'll talk about in one summarizing slide from the ASLD, but it is extremely difficult to implement the frequency and the intensity that we are talking about. If one were to look at even individuals as us, how often are we able to stick to that, and how long are we able to perform that? And we are expecting these sick patients to perform this level. So I think this is something for well-compensated cirrhotic who is an outpatient setting, who can perform things a lot more. So which is the prevention stage is very important for. Lastly, about the testosterone, I already talked about that there are limited data, only one single randomized controlled study. We did improve the muscle and bone mass and decrease the fat mass, but overall other benefits were not observed. But cautious use in those that have a history of both personal or family history of hepatocellular carcinoma, venous thrombosis, or other inclusion criteria. So this is the guidelines, similar concept as what we talked about in the earlier. So liver-specific management of disease etiology, management of ascites and encephalopathy, physical activity we just talked about, guided by the FIT, but remember who all can achieve this, and targeting the right patient, right time is important. Again, nutrition we talked about, so intake and uptake is very important. Again, recognizing how, who, when is critical, and earlier the better, so that the disease is not progressed and it's harder to reverse in that stage. Testosterone we talked about, and then the role of better metabolic control and behavior specialist is important. So what are our future directions? So I would like to say that we have made a lot of progress. This is a huge step in the right direction for our community, that we are able to put forward a concise and organized statement and guideline. But still, there are gaps in standardizing feasibility in assessment of frailty and sarcopenia in diverse population, in diverse setting, with respect to like differences in sex or gender, race or ethnicity, and the acuity of illness, as we see that our patients fluctuate from very stable, like looking, to very sick in ICU setting. So that needs, like there are a lot of scopes right now to look in that direction. Longitudinal assessment of frailty and sarcopenia is another big area in how this may impact. There are already some encouraging data that we can leverage. And then there's development of therapeutics and multimodal strategies targeting frailty and sarcopenia, more so like integrating multiple specialties and utilizing both the trials, utilizing the products that can modify and improve both frailty and sarcopenia. It will be a huge direction for our future direction for our cirrhotic population. So thank you for your attention, and I would be happy to go over the discussion.